holding another hearing on this important topic. In Westchester County, part of which is in my district, 124 people died due to opioids in 2016, and in the Bronx, in New York, which is part of my district, more New Yorkers died of overdoses than in any other borough of New York City. We must do more to turn the tide of the opioid epidemic, and we cannot hope to do that if we fail to recognize the importance of Medicaid. Medicaid covers nearly 4 in 10 non-elderly Americans grappling with an opioid addiction. Through the Medicaid expansion under the Affordable Care Act, states were afforded new resources to cover Americans living with substance use disorders and get them the treatment they need. We must continue to expand states' capacity to combat the opioid crisis and take care to avoid hamstringing that capacity in any way. This brings me to a number of bills we're considering today that I fear could hinder states' ability to address this crisis: the Medicaid Pharmacy Home Act, the Medicaid Drug Improvement Act, and the Medicaid Partnership Act. I worry that asking states to make complicated changes to their Medicaid programs in less than a year sets them up for failure, and since non-compliant states will be punished with FMAP penalties, states' ability to deliver treatment and recovery services could be hampered as a result. I also have concerns regarding the Medicaid Graduate Medical Education Transparency Act. In my opinion, the reporting required under this bill is overly prescriptive and burdensome and may take up limited resources states have for Medicaid GME and for all for reporting that will not tell us very much. And I've heard similar concerns from stakeholders as well. After all, Medicaid spending constitutes just 16% of federal spending on GME, so this reporting would offer an extremely narrow picture of the training physicians are getting. I also worry that the information gleaned from these reporting requirements could be viewed as a microcosm for a state Medicaid program's holistic efforts to combat the opioid crisis, but it's my understanding that those efforts involve many facets of the healthcare system, not just physician training. So, Mr. Douglas, I want to ask you, is that a fair assessment? That the efforts involve many facets of the healthcare system, not just physician training, and that information gleaned from these reporting requirements could be viewed as a microcosm for a state Medicaid's program's holistic efforts to combat the opioid crisis.
I'm sorry. The question.
Okay. Let me move on. I'm not opposed to collecting more data on Medicaid GME or other GME programs. However, I think we need to be more thoughtful about the data we're asking states to collect. We're facing a shortage of providers, of SUD providers, but I don't believe this bill would address that, and solving the problem cannot be left solely to a group of specialists with specific training in substance use and addiction. A more comprehensive approach is needed. We need to be thinking about the full spectrum of providers and their roles in solving this crisis. Mr. Douglas, let me try again. How can we improve and build our workforce, that SUD providers and others, to help end this epidemic?
Great. So, as I noted in my written testimony, as well as the chairman mentioned, I think an important area, we're focusing as a managed care organization at Centene, as well as states, is around ways to make sure that we're educating providers and disseminating that education. Project ECHO is a great way of doing telementoring opportunities and really spreading, especially as it gets to rural and underserved areas. So we have to focus both from making sure we're educating on the prevention side, but then, as you noted, there has to be a continuum of services and treatment modalities. And from the lens of MACPAC that we've seen identified, there's a wide variety disparity that you might have in Boston, a large array of treatment modalities, but in many states the modalities aren't all there, and so the continuum of services on the treatment side, from both outpatient to peer support, to MAT-related services, and of course, as I mentioned before, there needs to be residential where appropriate on the evidence base, and that means eliminating the IMD exception. So those are all approaches that need to be taken.
Thank you. Let me quickly go to Mr. Botticelli based on some of the comments that were made before I gave my question. Do you have any concerns about rolling back 42 CFR Part 2?
I do, both as a policymaker and a person in long-term recovery. Unfortunately, substance use disorders are different from other diseases. They're still highly stigmatized. They're subject to discrimination and criminal penalties. SAMHSA, I think, and this is fully supporting the fact that to give people good care, we need to integrate physical care with part of their substance use disorder treatment. I think all of us support better integrated and holistic care. But I do think a patient should have a right to consent to disclose their records. The Substance Abuse and Mental Health Services Administration actually just modified their regulations twice to support enhanced integration of 42 CFR Part 2 treatment information into primary care records.
Thank you, Mr. Chairman.